Thank you so much for the organizing committee to invite me here to present this. First, I have nothing to disclose. And second, I have been asked to debate Dr. Hamadi for doing open surgery for redo pyeloplasty. For the first instance, from my point of view, I am not defending about giving up doing minimally invasive redo pyeloplasty. But before going through this, we have to consider open surgery first and its importance. We will see now how it looks like from the literature point of view and some technical steps. So first of all, I have went through the literature to find out what is have been published about redo pyeloplasty, open versus robotic approach or minimally invasive approach. And I have found only 2 articles, one in the Journal of Urology published 2007 and one later on 10 years later. And it's interestingly was published by the group for which Dr. Hamadi was participating in. So we're gonna see how the results were for both articles. The first article in the Journal of Urology, as we can see here, they have a limited sample size. 6 patients underwent laparoscopic pyeloplasty, redo. We are speaking about redo pyeloplasty versus 5 cases of open pyeloplasty. As we can see, and as expected, that the operative time was significantly shorter for the open group, while all other things were comparable apart from the length of stay and the number of complications, which was in favor of laparoscopic redo pyeloplasty. So, to take home message from this article, only in experienced hands we can speak about laparoscopic redo pyeloplasty. The next one, which compared 24 patients underwent redo laparoscopic pyeloplasty versus 15 open pyeloplasty done by the same surgeon, he is an experienced open and laparoscopic surgeon. We can see here what's in favor for open versus redo laparoscopic pyeloplasty. The operative time was significantly lower for patients underwent redo open pyeloplasty, and also the mean blood loss was significantly lower. And as we can see, the success rate was 100%. Also, it wasn't not statistically significant from that of the redo laparoscopic pyeloplasty. On the other hand, we can see that hospital stay and the number of intravenous analgesic injections were significantly lower for those who underwent laparoscopic redo pyeloplasty. I quote this from the conclusions of the authors that the laparoscopic redo pyeloplasty is a viable alternative and a technically demanding procedure. It should be done in high volume centers and in those surgeons with a considerable experience in laparoscopic and reconstructive surgery. Lastly, I have found recently in last year a meta-analysis that have been published focusing on 6 articles on the topic. And as we can see from the results of this meta-analysis, that there is no significant difference between any of the studied items after correction with regard to the operative time, length of stay, complications, and success rate. But because of this limited published data about this topic, I went backward, a step backward to see what is the difference between the laparoscopic and the open pyeloplasty itself, to delineate the difference. First, the last updated meta-analysis on the topic, including 16 studies. This was published 3 years ago. And as we can see that the length of stay, of course, in favor of laparoscopic pyeloplasty, while the operating time was in favor of the open technique, and the success rate was equal in both groups. So it's only as we can conclude, it's only a matter of the surgeon experience and the learning curve. The learning curve, this is something to be put in mind while before starting on this such complicated and complex procedure. There is no published literature about the learning curve for such redo cases, but if you can see, I quote this article about the learning curve for laparoscopic pyeloplasty. This group of authors have compared the results of the first 50 cases to the next 50 cases. And as we can see, they denoted that 50 cases was a cutoff point above which the complications, the operative time, and the blood loss, and everything was significantly different from before and after doing the 50 cases. So you need at least from this article 50 cases of laparoscopic pyeloplasty to make sure that you are achieving the optimum outcome. One more point is the need for ureterocalicostomy. We know that in redo cases of pyeloplasty, we have limited options, but for long segment strictures and when the pelvis is intrarenal and when there is a lower polar hydronephrosis, you might need a ureterocalicostomy surgery. So this raises the complexity of the case even more, because you have to dissect the lower bore, you have to dissect more at the ureter, and you have to do more challenging anastomosis. So if we considering redo pyeloplasty, it should be done by a very high volume surgeon in a high volume specialized center. So the harvest of that is the training on open, de novo, or redo pyeloplasty is essential, and the laparoscopic approach should be reserved for a specialized center as well as well-experienced laparoscopic surgeons. It is not the approach, it is the surgeon experience in certain approaches that determines the ultimate outcome. Thank you, and I invite Dr. Hamadi for coming.